You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for September 23rd, 2022. This week, we're going to be talking about cerebral protection after TAVI, renal denervation, left atrial appendage closure, and deprescribing aspirin. First topic today is the PROTECTED TAVR trial. Now, stroke is one of the most feared complications after transcatheter aortic valve implantation, or TAVI. And it's easy to forget what a TAVI actually is. It is placing a new valve without removing the old one. The action verbs that fit here are squish, crush, smush. Now, all that smushing creates debris that can then travel north to the brain. And placement of a filtering device north of the aortic valve, but before the brain, a device that catches debris, seems like a sure bet to reduce stroke after TAVI. Now, the weird thing is that this device does catch ugly-looking debris, but a previous trial had showed no difference in the size of defects on MRI or any changes in cognition. And of course, the filtering device isn't free. It adds cost to the procedure. It requires a separate arterial access, and just placement of a device in the great vessels may dislodge debris that then can cause stroke. So it needs to be studied. The PROTECTED TAVR trial randomized about 1,500 patients after TAVI to the device arm and 1,500 patients to TAVI without cerebral protection. The endpoint was stroke, a symptomatic defect that correlated with imaging. That sounds pretty straightforward, right? Yeah, I wish. Stroke after TAVI occurred in 34 patients, 2.3% in the protection arm, versus 43 patients, 2.9% in the control arm. The difference was 9 strokes, and that 0.6% absolute risk reduction did not come close to reaching the accepted threshold of statistical significance. Now, in relative terms, the relative risk reduction was 21%, and the confidence intervals went from 0.51, or a 49% reduction, to a 1.23, or 23% risk increase. The p-value was 0.30, not 0.06, not 0.1, but 0.3. Now, that means that if we assume the cerebral protection device had no effect, that's the null hypothesis, and then we repeated this experiment many, many times, we could see these results in 1 out of 3 experiments. In other words, it's not at all surprising data given the assumption of no difference. Now, our accepted threshold of statistical significance, which many think is too lenient, is 6x greater at a p of 0.05. So one would think the easy answer of PROTECTED TAVR would be, given the previous trial showing no benefit in reducing MRI defects, and now this much, much bigger trial with hard outcomes that's clearly non-significant, we can conclude that this device doesn't work. Well, no, that is not what happened. No, not at all what happened. Instead, 2 other things happened. One was that the New England Journal of Medicine, that's right, the New England Journal of Medicine, the strict New England Journal of Medicine, allowed this statement in the conclusion of the PROTECTED TAVR trial. They wrote, among patients with AS undergoing TAVI, the use of cerebral protection did not have a significant effect on the incidence of periprocedural stroke, but On the basis of the 95% confidence intervals around this outcome, the results may not rule out a benefit of cerebral protection during TAVR. That's amazing, that last phrase. Now, statistical experts will rightly push back against the whole idea of dichotomizing trial results into something works or it doesn't work based on a confidence interval and a p-value. But I've never seen this sort of phrase before, especially in New England. Now, the conclusion is correct, actually, but it's incomplete. It is true that the 95% confidence intervals of PROTECTED TAVR allows for a 49% reduction in stroke, but it also allows for a 23% increase in the risk of stroke. And why do you not have to state that as well? Now, that is not at all that happened to spin this trial. At the TCT conference, the authors, and actually the panelists, drew attention to one of 15 secondary endpoints, and that was disabling stroke. And disabling stroke in this trial occurred in 8 patients, 0.5% in the protection arm, versus 20 patients, 1.3% in the control arm. The 0.8% lower risk had 95% confidence intervals ranging from as low as minus 1.5% to minus 0.1%, and thus met statistical significance because the confidence interval did not cross 0. Now, the delta here was 12 strokes in a trial of 3,000 patients. This emphasis on one of 15 slightly positive secondary endpoints is deeply problematic. The authors and panelists justify it on the grounds of plausibility because they say the device catches large debris and large debris is more likely to cause disabling strokes. But I'm not buying that because one problem is that stroke location can be as important as size. A tiny clot in a crucial area can be disabling. You can have a huge clot in the right frontal lobe and cause a massive infarct, and patients can be asymptomatic. Now, another problem with this whole business about disabling stroke is statistical. It's one of 15 secondary endpoints in a trial with a decidedly non-significant primary endpoint. Never forget Richard Peto's publication in The Lancet, ISIS-2 trial, wherein he showed that astrological sign could determine aspirin benefit after MI. His point was that if you look at enough outcomes after the primary endpoint, you will get some that turn positive by chance alone. Now, the final issue with disabling stroke is that it requires even more adjudication. And anytime you add adjudication to an endpoint, you add a risk of bias. Now here, it's especially problematic because the modified Rankin scale is extremely subjective and there's inter-observer variability noted. So my final comments, my friends, I wish this device reduced stroke. There did not seem to be an increase in complications. But the problem is that stroke rates after TAVI have already been driven quite low. And if we allow trials with a 0.6% absolute risk reduction and p-values of 0.3 to be spun positive by proponents, then why bother doing trials? Why not just let the experts tell us what to do? Why bother with evidence at all? Proponents of doing costly invasive procedures must bear the burden of proof. If this trial gets close to that threshold of proof, I shudder to think how much low-value care will be allowed. Now, I realize that some will say the trial's underpowered because event rates are low, and if they had recruited more patients, then it would show a benefit. My answer to that is you don't know that. It could have trended worse. There were 3,000 patients randomized, 3,000, and this was not enough to show a difference. Okay, finally, if any editor of the New England Journal of Medicine accidentally happens upon this podcast, I want to ask them, why now? What about Dankavas or Paragon HF or a host of other trials that came close but did not meet the accepted statistical threshold? This is a real question. I'm really interested and curious. Okay, next topic is renal denervation. I'm seeing a very worrisome trend in the renal denervation space. While there is no doubt that newer generation devices provide a statistically significant, albeit small, sham-resistant drop in blood pressure over the short term, say months, and Foy's group at Penn State has probably the best meta-analysis on this, It's in Trends in Cardiovascular Medicine. First author is Mo Ahmed. They looked at 10 RCTs with sham control. There's a 2.6 millimeter of mercury sham-resistant lowering of blood pressure in the renal denervation arm. But in their meta-regression, studies that followed patients for longer than 4 months had numerically lower reductions in most blood pressure outcomes. I'm concerned with the push to convince us that this effect is durable over the long term. And I've previously reported that the interpretation of the follow-up of the spiral hypertension on trial, which showed reductions of blood pressure at 36 months, are deeply, if not fatally flawed because of unmasking of the patients. Now, lest we forget the intense excitement regarding the non-sham controlled pre-Simplicity 3 trials, which found huge, massive reductions of blood pressure. Then, boom, Simplicity 3 with its proper sham showed no significant reduction. At the TCT conference, we heard results of the follow-up study from Simplicity 3. Now, Steve Stiles is one of the most experienced health reporters in the business, and his lead of his news story exactly captured what the authors of Simplicity 3 want us to know about their follow-up study. Here is what Steve wrote in the lead. There's an intriguing plot twist in the story of Simplicity Hypertension 3, the sham-controlled clinical trial that nearly put the kibosh on renal denervation therapy as a promising approach to treatment-resistant hypertension. The trial famously showed no benefit for systolic blood pressure from the invasive procedure at 6 months or 12 months, and it dampened enthusiasm for renal denervation and hypertension for both doctors and industry. But it turns out that disappointment in the study may have been premature. The procedure led to significant improvements in blood pressure, whether in-office or ambulatory, compared with a sham-controlled procedure in a new analysis that followed the patients out to 3 years. Steve then quotes the PI of Simplicity 3 and this reanalysis, Professor Deepak Bhatt. Quote, "These findings support that durable blood pressure reductions with radiofrequency renal artery denervation." Steve's job is to report the news. The TCT news was, don't worry folks, renal denervation provides durable control, and better, the effects may actually improve over time. While Steve reported it beautifully, my job is different. My job is to critically analyze these conclusions. And I will say with little doubt that these conclusions are surely wrong. And let me explain. First, let me tell you about the follow-up study, its conclusions, and then why it's wrong, as were the conclusions from April's spiral hypertension on unblinded follow-up study. In the original Simplicity 3 study, renal denervation was tested in a 2-to-1 randomization against a sham control, and the researchers were careful to maintain blinding. That trial found no significant difference in blood pressure over 6 and 12 months. Now, I know there are many reasons why this may have been. I mean, there was possibly inadequate ablation, for instance, but the fact remains that it did not reduce blood pressure. Now, the Simplicity 3 authors offer a follow-up study in which patients were unmasked at 6 months. About 360 patients started in the active renal denervation arm, and about 170 patients started in the control arm. After unmasking, 100 of the 170 had crossover to renal denervation, and about 70 did not. So in this follow-up study, the active arm was the renal denervation arm carried out over 3 years, and the comparison arm included the non-crossed over patients and data from crossover patients at 6 months before renal denervation, and they used the most recent pre-crossover blood pressure to impute subsequent follow-up data. And the results here were clear and massive. Renal denervation reduced office systolic blood pressure by 26 millimeters in the renal denervation group versus 5 to 7 in the control group. The delta was huge, like 20 millimeters of mercury or more. The authors, most of whom are experienced trialists, made this conclusion. Quote, "The final report of the Simplicity Hypertension 3 trial adds to the totality of evidence supporting the safety of renal artery denervation to 36 months, and from 12 months to 36 months after the procedure, patients who were originally randomly assigned to receive renal artery denervation had larger reductions in blood pressure and better blood pressure control compared with patients who received sham control." Now, I read their limitations paragraph in the Lancet, and they hardly mention the elephant stomping around in this room, which is the unmasking. So to sum this up another way, when under masking conditions, there was no difference in blood pressure. But after unmasking, you observed better blood pressures in the renal denervation arm and higher blood pressures in the non-crossover group. The difference in this study was very similar to the findings in the unblinded Simplicity 1 and 2 trials. You know, the ones that started the massive enthusiasm for renal denervation until the sham-controlled Simplicity 3 trial shut that down. So, my comments, my friends, do not be misled. The reason there are placebos and blinding is to control bias. The main problem here, as so clearly noted in the accompanying editorial from Drs. Fanelli and Pursue, is the unmasking. Once you do that, the game is over. Not only are patients unmasked and open to different behaviors and adherence, but the clinicians are also unmasked, opening up the possibility of performance bias. Now you might ask, how do you know there was bias, Mandrola? And my answer is that if there wasn't bias in unmasked comparisons, we would never do placebo-controlled trials. Of course there's bias. Here, bias from unmasking is the largest problem, say 80% of the problem, but there are other problems as well, and one of them is imputation of blood pressures before renal denervation in the crossover arm. When you take the last blood pressure before an unmasked patient in the control arm has renal denervation, you may be, as the editorialists write, crystallizing the highest blood pressure. And if you do that, you bias in favor of renal denervation. And in fact, when the trialists did their analysis without imputation, table S4 in the supplement, there were no differences in blood pressure. Now, yet more evidence for bias comes when looking at figure S5 in the appendix, which graphs the systolic blood pressure in the crossover and non-crossover patients from baseline. The patients who did not cross over had a reduction in blood pressure when they were in the masked part of the trial in the first 6 months, but then had increases in blood pressure after they were unmasked. This observation strongly suggests a Hawthorne effect during blinding, meaning that during the trial when they did not know which therapy they had, and it could have been renal denervation, they had better adherence to lifestyle and medications. Look, many of you think I'll oppose renal denervation. I don't. I'm open to this. Newer generation devices seem to have a sham-resistant effect over the short term, and there's clear potential because medical adherence to blood pressure medicines is obviously suboptimal. But hypertensive treatment is for years, not months. Renal denervation is invasive and it's costly, and the only way to prove it works is to maintain blinding over years. I don't see why you couldn't maintain blinding. I mean, you could do a trial and put in rules to up-titrate patients in either group who have dangerously high blood pressures. And the argument that resistant hypertensive patients must be crossed over to renal denervation is a very specious one because it assumes renal denervation works, and I don't think we know that yet. As there is with any new technology, there is a lot of financial and intellectual dualities of interest in play here. And I really worry that complicated analyses like this, ones that carry the provenance of big study names like Simplicity 3 or Spiral Hypertension, hide the fatal flaws inherent in unblinded observational comparisons. I think the answer is not to publish these papers, but show consumers of medical evidence that renal denervation works over years, not months, by maintaining blinding. One more time, I want to shout out to the editorialist who wrote one of the best commentaries I have seen in a long while. Congratulations. Third topic today is left atrial appendage closure, and this will be brief. A colleague called me this week to tell me that they've dealt with 3 Watchman complications on their service in 1 week. The TCT conference featured a head-to-head randomized trial comparing Boston Scientific Watchman to Abbott's Amulet. These are 2 devices used to occlude the left atrial appendage percutaneously. The results were largely comparable, and I highlight this study not to tell you the results, but to illustrate exactly what happens when lenient regulatory approval meets a rapturous audience of physicians who like doing procedures. The trial results made news. It was a feature study of TCT, yet there exists no compelling evidence that either of these devices is better than a DOAC or no treatment. It's like a tragic comedy. You're studying 2 types of devices and you don't even know if either of them work. Recall that Watchman was approved despite not meeting its first co-primary endpoint of stroke, embolism, and CV death versus warfarin in PREVAIL. Watchman was not non-inferior to warfarin in that endpoint. Now, patients who had reasons not to take oral anticoagulation were excluded from the pivotal trials, and we have yet to generate any convincing evidence that this procedure helps these people, despite years. The Amulet IDE trial randomized about 1,900 patients to either device. Now, why would we not want a no treatment arm in this trial? It's a perfect opportunity to learn. Now, I did lie a little bit. I will tell you one result of this trial. The rates for procedure-related complications were 4.5% with Amulet and 2.5% with Watchman. Now, if you had a no treatment arm, they would start that follow-up period without the risk of a complication. It'd be like a 10-mile head start in a marathon. Now, the second story on left atrial appendage I want to update is my coverage last week on death rates after the procedure. Recall that Canadian and Spanish investigators found that in a contemporary multinational European series of patients, 1 in 6 patients died in the first year, so-called early death. And based on what I've seen for referrals for Watchman in the US, I bet our numbers in this country are even higher than that because we do this procedure on very sick elderly patients. Now, these sorts of patients have no chance to benefit from left atrial appendage closure because the procedure is designed to reduce bleeding and stroke over years, not months. Journalist Patrice Wendling has excellent news coverage of this study. And one of the debates that she covered in the study is that the study authors called the procedure futile if the patient has an early death. The editorialists pushed back on that. I actually side with the study authors because if you do a preventive procedure for one disease and the patient was sick enough to have died in less than a year from other diseases, then the only people that have been helped in this situation are the device makers, doctors, and hospitals. Okay, I realize, I'm aware of, many listeners may be tired of my railing against this procedure, and I'm sorry, but it is deeply troubling to me to see my colleagues embrace such an invasive procedure that is so devoid of convincing data. I mean, this looks to be destined to become like the thrombolysis and acute stroke issue, which is also based on extremely dubious data in the seminal trials. And if an RCT of patients shows benefits, I would change my mind. But the problem is that when there's regulatory approval, and key opinion leaders are promote something so strongly, like they are with appendage closure, then it becomes very difficult to do such a trial because therapeutic fashion has already been ossified. And then this week we have Abbott, the company that makes Amulet, tweeting their commercial, picture of an old couple on a beach with a grandson. The text says, quote, "Life is the outcome that really matters. In the Amulet LAAO RCT, CV and all-cause death trended lower after 3 years with Amulet. See 3-year data." Look, I don't blame industry for these kinds of ads. Their task is to sell units. I blame us, physicians, and our lax critical appraisal and extreme susceptibility to being bamboozled. Okay, final topic is aspirin deprescribing. Aspirin, especially in the presence of oral anticoagulation, is by far the most common drug that I deprescribe. When there is no clear aspirin indication, there is just no evidence that the use of both oral anticoagulants and aspirin provides benefit. There is, in fact, evidence of harm in the form of bleeding. But doctors and patients tend to do it. The soft thinking goes, you use oral anticoagulation for prevention of thrombus from low-flow systems in the LA or peripheral veins, and you use aspirin for prevention of arterial thrombus in the coronaries or brain. One of the hardest challenges is getting aspirin stopped. People are attached to it. University of Michigan researchers led by Jeff Barnes, first author Jordan Schaefer, published a neat ecological study in JAMA Network Open on the effects of a quality initiative project in 6 anticoagulation clinics in 6 different medical centers in Michigan. Now, their written paper, I have to say, is complicated, but they have these great figures, and the figures tell the story. Go look at the paper. It's open access. Basically, they got anticoagulation clinics to identify patients on warfarin and aspirin who do not have an aspirin indication, such as a recent stent or CABG or stroke, etc. They then studied the effects of an aspirin deprescribing intervention, which was as simple as communication with the primary care clinician to say, hey, there isn't a clear reason to give aspirin along with warfarin. They then monitored aspirin use in these years before the intervention. They then took a block of time right before the intervention and a block of time right after the intervention. And again, the figures hold the key to understanding. In the 2-year pre-intervention period, there was sort of a steady decline in aspirin use because that's just been what we've been doing. But it wasn't a very steep decline. Then in the 24 months after the intervention, aspirin use plummeted. It was a much sharper decline, showing that the intervention clearly worked. They then looked at rates of bleeding and thrombotic events in the system, and bleeding rates declined as expected, and thrombotic rates did not increase. Now, I know this is observational data. The way to answer this question is to do a de-implementation RCT, and it probably could actually be done pragmatically and embedded in an electronic health record, or perhaps that's even in the planning. But until that is done, here is my take. There is not a shred of evidence that the combination of aspirin and anticoagulation provides benefit in the absence of a clear aspirin indication. There's strong evidence that it associates with increased bleeding, and that's plausible. The proponents of more therapy, of doing more, should always face the burden of proof. So I would say, in the absence of any clear aspirin indication, which are becoming less and less common, I say use oral anticoagulation alone on the principle of first, do no harm. And I say good work to the Michigan team. This is a neat study. And so that's it for this week in cardiology. As always, I'm grateful that you listened. And please, if you like this podcast, it really helps to just do a rating, a 1 or 2 sentence review. These tiny little things help others find us, and I really appreciate if you would. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.